asthma's easier to reverse, edema is not. Edema takes days to weeks sometimes to reverse. So we want to prevent. Prevention is the key for asthma. And we talked about increased mucus production. So the mucus that is produced in asthmatics is usually it's called mucoid. What does that mean? Mucoid. Joe, do you know? Do you remember mucoid?
Does it mean thick?
Yeah, so it's it's more of a sticky white kind of texture. So asthmatics get this sticky kind of secretions that block their small airways, so they feel more short of breath until they can cough that up. Okay, and our leukotrienes are the problem child that causes that. So let's see, the inflammatory cell involvement. So this is really complicated. And I'm just giving you guys the basics. So as I said, the eosinophils in extrinsic asthma are highly increased. Not as much in the intrinsic, but intrinsic, they have higher neutrophils. So you're definitely having the immune response that's causing the bronchoconstriction and these reactions, the edema. Okay, and this is a really great picture. So this shows you the mast cell that's degranulating. Let me see if I can get my little pointer here, laser pointer. So this is your mast cell. Here's the airway. Here's that sticky white kind of secretions that are kind of yucky, or edema that can be increased by your second response. The constriction, the smooth muscles that constrict to tighten that airway, which is going to cause increased resistance. And sometimes you can bronchoconstrict so much that you cause the air trapping, right, that we have. That's why they're resonant, they're hyper-resonant because of air trapping. Okay, so that's kind of a cool picture. Okay, so here's a normal bronchial, and here's one of an asthmatic. So you see the constriction of the smooth muscles, and you see the edema in the interstitium. All that swelling constricts that airway. Okay, so if you have a straw at home, a really cool idea to see how asthmatics feel is to put a straw in your mouth, close your nose off, and just breathe through the straw, because that's kind of mimicking a constricted airway. And just breathe through that straw for just a minute and see how it feels. And these asthmatics are doing it for a very long time. So you can kind of empathize with your patient on how they are breathing, all right? That kind of lets you know what it feels like a little bit. So we talked about the eosinophils, all right? So they're definitely elevated in extrinsic asthmatics, and they cause a lot of problems in the airways. Some patients, if they have this constant irritant stimulus and they don't get rid of it or leave it, it can cause permanent damage if they are exposed to something for a long period of time. Okay, so I'm going to give you an example. So let's say somebody is around a chemical, all right? They are working cleaning houses and they're working around cleaning products, and they've been doing it, that you could be doing it for a few days. That constant bombardment of that chemical can cause this reaction that can actually cause, if once they have remodeling, that is irreversible, okay? So we don't want that to happen to these patients. So we're going to really work on their triggers and to teach them to stay away from chemicals, smoke, paint, all right, that kind of thing. So If they have long-term changes with the remodeling, all right, in these airways, they get thicker, they get stiffer, okay? So long-term, the muscle hypertrophies, what does that mean, hypertrophy?
Bigger.
Yeah, so it gets bigger. Yep. Increased goblet cells. What are you going to have an increase of?
Mucus.
Yes. Yeah. These patients, they can have from a short-term exposure, they could have long-term effects. Okay, so they could have increased goblet cells where they're going to have more secretions, and when they have airway remodeling, what's actually happening is that you have collagens that are going to the site to try to repair the site. So collagens are going to be causing like the surface to harden permanently. All right, so that's a long-term effect that we don't want to happen to our asthmatics. All right, this is just a picture showing you the chronic airway, and that's why they're calling it chronic. All right, because it's a permanent problem once the collagens are, come into place. So that's a bad situation right there. Okay, so this is just breaking it down, the physiological effects. So all of these things are occurring, and we talked about that on the board. Basement membrane thickening, so that's going to be narrowing your airway. Interstitial edema. All right, so how do you think these patients are going to look clinically in a physical exam? So if you go to see an asthmatic in a room, what do you think they're going to look like? Tell me some things you might see clinically.
Pursed lips.
Okay, so they're going to be split breathing. Why are they doing that?
To keep the airway open.
Right. Create backflow resistance, which actually stents the airway open. Right. Allowing them to exhale that air so it doesn't get trapped. What's a normal I/E ratio for a person? Normal I/E ratio.
1 to 3.
1 to 2, 1 to 3 is normal I/E ratio. If you breathe in usually about 2 seconds, exhale about 4. So it's usually a 1 to 2 ratio. Okay. Asthmatics, their airways are so constricted, it takes a longer time for them to get that air out. Okay, if you give them 6 seconds, 7 seconds to exhale, they might get all of the air out, but it's going to take them much longer to get that air out. So when we're ventilating these patients, if they have to end up on a ventilator, we need to keep that in mind that these asthmatic patients, they take a long time to exhale. So we want to make sure we give them that time to exhale all of the gas out of their lungs so they don't constrict. So that they don't air trap. Okay. Nina's just texting me something. What is she saying? I don't know what she's saying. Okay. So we talked about pursed lip breathing. So when you walk into a room, if an asthmatic, if you've never seen someone having an asthma exacerbation, it can be pretty frightening for you to see this patient because they can be, it's very scary not to be able to breathe. Very scary. So tell me about their position. How do you think they're going to be sitting or laying down if they're having an asthma exacerbation?
Tripod.
They're definitely going to be in tripod position. I'll tell you that. Leaning forward, right? They're going to be in that tripod position, trying to expand their chest wall and overcome all of that resistance. It's hard to breathe in and it's hard to exhale. All right, so they're going to be working really hard. So you're going to see them using their expiratory accessory muscles along with inspiratory accessory muscles. If they have hypoxemia, what would be the first sign of hypoxemia? First sign of hypoxemia.
Is it tachycardia?
Yes, very, very good. Tachycardia, okay? First sign of hypoxemia is tachycardia. Second sign, what's the second sign of hypoxemia?
Tachypnea.
Tachypnea. Two together, patient's hypoxemic. So we've got our little pulse ox. We're going to do our assessment on them. But you can see somebody who is in distress just when you come to the doorway. You can see their distress. So they're going to be leaning forward, using their accessory muscles. They could be retracting. And you can see retractions very easy with children because they have less muscle. So you can see the retractions easier with kids. They could have all of these symptoms when you go in to see them. So when they see a respiratory therapist, you're like their best friend because they know you're coming there to treat them, to make them feel better so they can breathe. So you get this personal relationship with these asthmatics that are, we call frequent flyers, that come in and out. So they really trust you, and they look forward to seeing you. So another one, pulsus paradoxus. We're not going to go too much into this, but briefly, just tell me, what is pulsus paradoxus? And why does it occur? Shown. You want to give it a shot?
It
Shown or did you follow?
with a systolic drop in your blood pressure.
Yep, on inspiration. On inspiration. And why does it occur?
It can be due to the negative interpleural pressure.
Right. So think about these asthmatics are using so much force to inspire air, right? They're causing a lot of negative intrathoracic pressure. And that causes the dilation, right? Which overs that right ventricle and decreases left ventricle preload and decreases cardiac output. Okay, so you'll only see that in a severe asthma exacerbation. Okay, so let's go on with that. Okay, so let's look at this. So prolonged expiratory phase, we just talked about that, right? Greater than a 1-to-3 ratio. How about tactile and vocal fremitus? What are you going to have?
Decreased.
Pardon me?
Decreased.
Good. Decreased. Percussion note.
Hyperresonant.
Hyperresonant. Then heart sounds. If you're hyperresonant, what do you think? Increased, decreased?
Decreased.
Decreased. What kind of breath sounds do you think you hear with an asthmatic?
Wheezing.
You're going to hear wheezing. What else would you hear with those increased goblet cells?
Crackles.
Crackles. First crackles. Yes. Are we good with this?
Yeah.
Okay, so you go into the room, you see your patient, and you see their distress level. So normally we like to do an interview and do a full assessment with them, but it depends on their distress level. If they're in major distress, you're not going to take time, 30 minutes to do an interview because they probably can't talk. So you're going to assess their distress level and treat them appropriately. If they are in distress, you're going to go right into doing a quick assessment, giving them their medication, and you can talk to them about why they're getting their medication. And the other thing is you want to try to keep them calm, all right? You want to let them know that you are there to help them. And just by saying that lets the asthmatic kind of relax a little bit because they need somebody to help them, and that's what you're there to do. So chest x-rays, okay? So this is a severe asthma exacerbation because Who can tell me some points about this chest x-ray that tells you this is a severe asthma exacerbation? Pate, I haven't heard from you yet.
The lungs is how do you call it? More
Hyperinflated?
Yeah. Also hyperinflated too.
Hyperaerated?
Yeah. And also,
Good.
yeah.
You see a lot of blood vessels?
No.
No, so you have decreased vascular markings because of the hyperinflation, right? Tell me about your hemidiaphragms.
Yeah, that's what I try to point it out. Diaphragm.
Oh, that's what you were pointing out, the hemidiaphragms?
Yeah.
So what about them? Are they dome-shaped? Are they nice and dome-shaped?
No, they don't.
Concave?
They're dome-shaped.
I didn't hear you. Yes, they are dome-shaped, or no, they are not dome-shaped?
They're dome-shaped.
Yeah, they're not. They're not dome-shaped nicely. They should be like at an angle, and they're not. So they're starting to flatten out because this patient is trapping gas. So they're starting to flatten out. And once you trap gas, so everybody take and I know you've done this before, but we're going to do it again. I want you to take a deep breath in and take a breath in on top of that. How did that feel?
Hard.
That's hard too, right? So if you have all this gas trapped, it's going to make it hard for you to spontaneously breathe because you're trying to breathe on top of gas that's already trapped in the lungs. Okay? So we want to get that gas out of the lungs. So this is a severe asthma exacerbation. ABGs. So we don't tend to do ABGs frequently for like an asthmatic that comes into the ER or the ED, unless we think that they're going into ventilatory respiratory failure. Other than that, we don't tend to do them that often because if they can't breathe, then we just need to treat them to fix that problem, right? We're not going to try to make them worse by sticking them. So that's left for patients that we want to see if they're going into ventilatory failure and we need to further assist them as intubating them. That's when we would do an ABG to make that determination. Should we intubate this patient at this time? So initially they come in and we're just treating them with meds, okay? But ABGs, they will let us know how the patient's doing. So if they have, let's see, these are our 4 stages of ABGs. So let's take note of this. So stage 1, all right? Stage 1 would be the patient's starting to have an asthma exacerbation, but it's in the very, very beginning. So they still have normal ABGs. Stage 2, they're starting to work a little bit more, okay? So we're blowing off a little bit of CO2 because why are we having a respiratory alkalosis? Why is that happening? Respiratory alkalosis, why is this occurring?
Is it because they're hyperventilating?
They are hyperventilating, but so that causes respiratory alkalosis. But why are they hyperventilating in stage 2? And Alicia, you already told me this answer.
Oh, because they tachycardia?
Well, they are tachycardic and they're hyperventilating, which is causing a respiratory alkalosis. Why are they doing that in stage 2? And I'm giving you the hint right here in stage 2.
Because they're hypoxemic.
Yes, they're hypoxemic, right? That's our response to hypoxemia. Okay? We have those J receptors that tell the brain to breathe faster because we're hypoxemic. So the brain breathes faster and you develop a respiratory alkalosis to try to increase oxygen to the lungs, to the bloodstream. Okay. And the heart kicks up and works faster to try to deliver that oxygenated blood to the tissues. That's why we breathe faster, and that's why the heart works faster, to get oxygen to our tissues. The body's trying to repair itself. Okay? So that's stage 2, mild hypoxemia. I want you to know these stages. Stage 3 is called the crossover phase, and this is highlighted in yellow. Okay? So this is a normal acid-base balance here, stage 3. So their pH is going to be normal, their CO2 is going to be normal, but they will be hypoxemic. Okay? Now, how can that be? That they go from a respiratory alkalosis and they're worsening, and now they go to a normal acid-base balance. Anybody take a guess why that is happening? So this is a worsening stage right here. Why do you think their their acid base is normalizing? Their CO2s were 27, now they're 40. And their pH is normalized. It's no longer alkalotic.
Because they're crossing over to the acid side?
They're crossing, yeah, exactly. That's why the crossover phase. They're crossing over to the acidotic side. Their blood gas is in the normal phase, but they're still breathing extremely fast. Okay, so you have this asthma exacerbation. You're tachypnic, right? Because you're hypoxemic. So if you're tachypnic, let's say you have a respiratory rate of 40, right? And initially, your 40 is giving you a CO2 of 27, okay? But you're still breathing 40 times a minute, but now you're getting tired. You can only do that for so long, right? So maybe after a couple of hours or hours of doing that, breathing 40 times a minute, your body starts to get tired. Your muscles are tiring out. So you're not blowing off the CO2 that you were doing at a respiratory rate of 40. So now your CO2 is climbing from 27 to 30, 35. Now we're at 40. So if you're breathing 40 times a minute and you have a normal CO2, you're in a dangerous phase. Okay? This is when we need to think about intubating a patient. So if you were to do a blood gas, your patient looks awful. They're so tachypnic. They're using all their accessory muscles. They're retracting. They can hardly speak a sentence, just a couple of words. And they're telling you they're tired. You know, and you get a normal blood gas. You draw the blood gas because the physician says, let's get a blood gas. And you draw it, and you have a normal acid-base balance. And the physician says, well, it looks good. It's normal. Looks good. Your job is to say, wait a minute. It's not good because the patient's breathing 40 times a minute. I think we need to intubate this patient. Okay, and sometimes patients will tell you, I'm getting tired. If they tell you they want to be intubated because they've been intubated before, listen to them. They know their bodies. Okay, and then stage 4 is advanced hypoxemia with a mixed acidosis. And this is the reason down here for the mixed acidosis. So you have a respiratory acidosis and you have a metabolic acidosis because of the anaerobic metabolism, right, which produces the lactic acid, okay, because of muscle fatigue and tissue hypoxia, all right, and that causes the lactic acid is increased acid in the blood, which is the metabolic acidosis. So if you're asked that, I want you to know the reason for a mixed acidosis, okay? So that's the crossover phase, stage 3. That's the big stage. All right. PFTs. So do you think we're going to do a pulmonary function test when the patient's having an exacerbation?
No.
No, we're not. We're not going to do that. We will only do a peak flow if they're able to do it. I mean, it's really great to be able to do a peak flow in a patient coming into the ED, just to see where they are at. But if they can't, we're not going to do that. We're going to treat them. Okay. So for pulmonary function levels, right? For obstructive lung diseases, your flows are decreased. Okay. Everybody write that down. Flows are decreased because of obstructive airways. So flows are decreased with obstructive diseases. So FEV1 to FVC, what is that? FEV1 to FVC. What does that mean? What am I looking at with that? Ion. FEV1 to FVC.
The maximum air exhaled in a second? Yep.
Forced expiratory volume that you've done in 1 second. So it's a flow. This is measuring a volume, but it's seeing how fast that you can do it in 1 second. Remember, asthmatics take many seconds to exhale all the gas out of their lungs, and it's looking at the patient's forced vital capacity. Okay. Forced expiratory flow, 25 to 75. What does that measure? Is that small airways or large airways? Small airways, right. We're indicative of asthmatics. They have small airway constrictions and decreased peak expiratory flows. Okay, so let's talk about if a patient comes into the ED and you're treating them and they're not responding to the drugs that you're giving them. So they're refractory to treatment. Okay, we call that status asthmaticus, and I want you to know this definition. So status asthmaticus, they're not responding to anything you're doing for them. That is serious. Okay, so it's life-threatening. It's an emergency. All right, they're failing to respond to conventional therapy. Okay, so here's some of the clinical signs that you will see. So, and I want you to know these also. Patients tachycardic greater than 120, so they're really, really working. Tachypnic greater than 30. Pulsus paradoxus. So we said pulsus paradoxus is greater than 10 millimeters of mercury on inspiration that it drops, right? Well, status asthmaticus is greater than 18. So highlight that, greater than 18 millimeters of mercury. Okay, so those are really significant for status asthmaticus. So we have the patient that came in and they're not really responding to therapy. They're getting tired. These are some of the symptoms that you could see that tell you as the practitioner, hey, this patient needs to be intubated. So a patient that's pretty serious, you're not going to put them on a treatment and leave, right? You're going to be paying attention to this patient very closely. So if they have a silent chest, what does that mean? Silent chest. What does that mean to you?
No breath sound.
Sorry, guys. I was about to have silent chest. I just aspirated water. Okay, go ahead.
Could it be like an asthma attack?
So it is an asthma, it is constriction, but these patients have constricted their airways so much, you don't hear air movement. Sorry, man, went down the wrong pipe. So these patients get really tired. And even speaking is pretty hard for them. So if you did a blood gas and you saw stage 3 or a metabolic acidosis, you know it's time to intubate. So guys, we're going to take 5 minutes because I need a 5-minute break.
Okay.
All right, I need to get this together.
Sorry, Johnny.
Thanks.
Journey.
Everybody there?
Yeah.
Okay. I'm back. You can hear my voice now, right?
Yeah.
I lost my voice.
If you drink a cold, a hot thing, it's good.
Say that again?
Drink hot thing, hot.
I was drinking coffee and water. Yeah. But boy, that was fun. That was rough.
It's
Okay.
Sometimes.
Nina said, "Can you finish?" I said, yeah, I can finish. I'm a trooper. Okay, so when physicians are diagnosing asthma, they, like I said in the beginning, they don't really, the first time a child has asthma, they're not going to diagnose it as asthma unless it's like a pattern. So they wait for a pattern or reoccurring symptoms, and then they'll find out, what's kind of triggering. Is somebody smoking in the house? The houses can make you really sick. So you want to make sure you clear your house of all the triggers that could be causing it. We talked about all these different triggers. Oh, morphine is a big one. So morphine, which is an opioid, right? It's a pain reliever. That causes histamine release, okay? And histamine, as we know, causes bronchoconstriction, because that's the first part of our response when the mast cell degranulates. So asthmatics should not get morphine. And I've had plenty of physicians trying to put some of my patients on morphine in the ICUs, and I have to let them know, look, they have a history of asthma. Let's pick a different drug. So that's something to keep in mind. So I'm just scrolling through these that I've already spoken about. And remember, we already talked about this, but diagnosing asthma, if patients given a bronchodilator and they have an improvement, remember, of 12% for their FEV1, okay, or 20% improvement on their peak expiratory flow rate, then that shows you that they're responding to the bronchodilator. So that's indicative of reactive airways. Okay, so that's what doctors look at. Another test that they can do is called the RAST, R-A-S-T, and you could see that on your board, some of these tests, the RAST tests, and these are fairly new. So this is a serum blood test to measure IgE antibody levels. Okay, they could also do a sputum culture and to see how many, if they have an elevated IgE amount. But this is a blood test, the RAS test, and their levels can be up to 10 times the normal amount. So highlight that. 10 times the normal amount as a non-allergic asthma patient. Okay, so their IgEs are elevated. We already know that. So this is another test that they do. It's called FeNO, fractional exhaled nitric oxide. Okay, so we normally have nitric oxide in our airways. So if we were to measure the exhaled air, we would have nitric oxide normally. But when it's increased, that tells us that there's inflammation in the airways. So they can actually measure it by having the patient do a test. Okay, they have them take a deep breath in and exhale very, very slowly, and they measure the amount of nitric oxide. So it tells the physician if there's an increase in airway inflammation. And that is one way. One of the things we do for FeNO is to diagnose asthma. So here's some indications, and I want you to know these, so highlight these. Indications for FeNO, they can use it to diagnose asthma. They can use it to differentiate asthma from COPD. So you're going to have an increased level of FeNO in asthma, not in COPD. Okay. It's also a good way for them to decide how much steroids they're giving the patient. So if they have higher levels of nitric oxide, then they're going to increase their steroid dosage. So it's also to monitor the steroid treatment. So those three things. And this is just kind of how it's done. I do want you to make note of the normal ranges, and it's measured in parts per billion. So normal range for adults and normal range for a child. Okay, so managing and treating these patients, as I said, you as the respiratory care practitioner need to develop a relationship with the patient so that they feel comfortable with you. And education is the key, because we want to prevent their immune system from responding. So we want to prevent them from their triggers so that they don't have an asthma exacerbation. Okay, because asthma can be life-threatening. And we don't want that to happen. So we want to educate our patients. One thing I didn't talk about in the beginning that I meant to talk about was what is it called, the guidelines internationally that they developed to treat patients with evidence-based medicine. Do you remember the acronym that we have in the beginning of this PowerPoint that we use for international? GINA. We have GINA guidelines, and that's what physicians use to decide how to treat patients. So we look at GINA guidelines. Even as therapists, we'll look to see, are the GINA guidelines, have they changed? What are they doing? And they've stayed the same for probably 20, 30 years. They've just recently changed about a year ago. And we are going to teach you the old way, but you could see a little bit different way in the clinical setting. Okay, so there is, under web links, there is a GINA guidelines pocket guide for you to review. Okay, so I put that there. Okay, so let's see, what else do we need to do here? Treatment. So we need to teach our patients how to do their peak flows at home, right? And establish their personal best so that they know how to manage their own asthma and how to stay away from their triggers. Let's see. Children. So we don't do spirometry on children. But here's a little cute mask, and I just actually got these pediatric masks in yesterday. So they have little masks that you can put on kids, and like a little dinosaur or a turtle. They have different ones to kind of make it fun for the kids. So some kids will let you do it and some won't. And if they don't let you do it, we'll teach you more in neonatal how to treat those children. We kind of do blow by for these kids that don't let you use the mask. But they should have SATs of greater than 95%. Okay, so if their SATs aren't coming up, you might want to have them, become inpatient so that they can be monitored a little bit closer. Okay, we all know about the peak flows, so we're not going to go over that. The pharmacological treatment, you guys are going to be quizzed on that tomorrow. Let's see. So for asthmatics, we said we start off with a bronchodilator, right? So we're going to do a SABA. So that's Amanda's calling me. That is the first line of treatment, is your SABA, okay? So if you're ever asked what therapy you want to do on a clinical simulation, your first line is going to be a SABA. You could add an anticholinergic second, okay? So if the SABA doesn't work by itself, then you can add the anticholinergic, which is ipratropium, all right? So we don't do those normally right off the bat, but we can add it because you're treating the front door and then you're treating the back door, right? So what system does albuterol work on? Sympathetic or parasympathetic?
Sympathetic.
Sympathetic.
It enhances the sympathetic. It's a sympathomimetic. How about ipratropium?
Parasympathetic.
Parasympathetic.
Good. And we call that a parasympatholytic, right? Okay. Okay, so here's some newer drugs, and this is more like an allergist or a pulmonologist might order these drugs for patients that have allergic type asthma or eosinophilic type asthma. So there's so many different phenotypes. You could have eosinophilic type, eosinophilic type, or non-eosinophilic type, but we're not going to go into all the different varieties that are out there. So I added a couple of sentences here to this slide to make it a little bit more clear about what these drugs do. So eosinophilic type asthma, which is allergic type asthma, one of the drugs that they can give is omalizumab, which you guys have learned about, Xolair, and that's an IgE blocker. So the IgE antibody, remember it sits on the mast cell? So this drug would bind to that antibody so that the antigen can't bind to it and cause that mast cell to degranulate. Does that make sense?
Yeah.
That's how that one works. The Nucala, mepolizumab, that's a monoclonal antibody. We've heard that term lately with COVID drugs. Monoclonal antibody, and that actually reduces the number of eosinophils in the body being produced. Okay, eosinophils can cause havoc on those pulmonary capillaries, which causes edema. So if we decrease the amount of eosinophils, we're going to decrease the allergic response. All right, so that's how those two drugs work. The IgE, I've just updated this slide. It's patients 6 years and older now, and I'll change the drug one to show that also. It is expensive. This would probably be ordered by an allergist. Okay, and there's your mepolizumab, also expensive, decreasing the antibody response. Okay, both in sputum and blood. Okay, corticosteroids. So we'll talk about the steps in just a minute. But corticosteroids, GINA guidelines have decided that this is really the most effective drug because the major problem with allergic type asthma or extrinsic asthma is inflammation. So we need to tackle inflammation. And does albuterol tackle inflammation?
No.
It does not. What does albuterol do?
Bronchodilate.
It just dilates. Exactly. The constriction from the smooth muscles. It relaxes, it bronchodilates, relaxing those smooth muscles. So it doesn't do anything for inflammation. So we have to do both. We have to hit both problems. So we really need to add corticosteroids. If you add corticosteroids, you're going to decrease mortality rate for these asthmatics. Really important. So we can give it either inhalation or systemically, as you guys know. With inhalation, how long does it take to be peak effect for inhalation corticosteroids? What's the time? So if your patient starts on an ICS, how long before its peak effect will take place? What are you going to tell the patient? 1 day, 2 days, a week, 2 weeks?
Twice. 8 weeks.
2 weeks, right? For peak effect. That doesn't mean that it doesn't start working when they start taking them. That just says that's their peak effect. So usually these patients, if you have a patient in the ED or in the hospital, they've stabilized them, they've been admitted, they're at the hospital, they're on oral steroids, systemic steroids. They will start them on inhaled corticosteroids if they think that they're going to be sending them home because they know it takes a couple of weeks for peak effect. All right? So they could still be on systemic steroids, but they're going to start those inhaled corticosteroids just because they know it takes time for those corticosteroids to take peak effect, okay? So, systemic steroids in the hospital, anybody think of a name of a steroid that we give in the ED? I don't know that we talked about it last semester. Did we talk about solumedrol?
Yeah.
Okay, so write that down. Solumedrol is what we're going to be giving in the ED, usually IV. Solumedrol. So if you have a patient that's coming in and you are giving them, how do we treat them when they first come in to the ED with bronchodilators? What are our two pathways?
IV.
No, how are we treating them with the bronchodilators? How do you give it? What's the two options you have to give a bronchodilator?
SVN or MDI.
So we never give MDIs in the ED to a patient who has an exacerbation. Why is that, Caitlin? Why don't we give an MDI to a patient?
Because you have to take a deep breath in with it.
Huh?
They can't take a deep breath in.
Yeah, and they can't hold, right? Because they can't breathe. So that's not going to work for them. So you have to give an SVN. That's number one. Did everybody hear that?
Yeah.
Yes.
Okay. So no answering MDIs on an exam for an asthmatic in the ED. All right, SVN. Now, there's two ways to give an SVN on an asthmatic who is not responding to the first SVN of albuterol. What are those two ways? Demi Lola.
So they will be given every 2 to 4 hours.
2 to 4 hours is for a COP patient. So you might want to write that down, which Nina will teach you about. 2 to 4 hours is a COPD patient because they are not reversible. Asthmatics are reversible. So does anybody want to take a shot on how often we're going to give this SVN? They're in quite distress. They're in distress, and you're trying to break this bronchospasm. So we're going to give albuterol, 2.5 milligrams, right? Initially, do that how often?
Every 4 to 6 hours.
No, we're on the systemic corticosteroid slide, but we're talking about albuterol. Can we give it more than within an hour period for albuterol?
Every 20 minutes.
You do it every 20 minutes.
Yes, you guys not remember that? Yes.
I do now.
Yes, this is huge. You guys have to know this. So you can give the albuterol Q 20 minutes. Write this down so it's in your head. Q 20 minutes times 3, okay, within the first hour. All right? That's 2.5 milligrams. So what's the total milligrams you're giving this patient in an hour?
7.5.
Correct. 7.5 milligrams is the total that you're giving in an hour. And what are we going to give this with? Are we going to put it to oxygen or air? Oxygen. Yeah. Causes pulmonary vasodilation. So we're gonna deliver this drug with oxygen. Okay? And so that's one way we can do it. What's the second way that we can do albuterol? If the patient did not respond to the first one and they look pretty severe, they're in quite a lot of distress. What is the second way we can do this?
Continuous SVN.
Yes, a continuous nebulizer out with albuterol. Yes. How many milligrams per hour can we give? 10 to 15. Write that down. So those are the two ways. One way is to give an SVN 2.5 milligrams, Q 20 minutes times 3 within the first hour. The second way is to give a continuous neb at 10 to 15 milligrams an hour. So studies have shown that if you give more of the drug, 10 milligrams versus 7.5, they have better outcomes. So if you have a patient who looks pretty distressed and is not responding, don't waste your time. Set up a continuous neb for 10 milligrams an hour. Okay? So when you're asked on a test, you can answer either way to give your bronchodilator. Is that understood? Everybody get that?
Yeah.
Yes.
Okay, so first thing we do, we give our bronchodilator. Now, if they're still wheezing, is there anything we could add to that albuterol to help them out? In that albuterol neb, is there anything we can add? So you have an SVN and you have albuterol in there. Is there anything you can add to that albuterol if they didn't really respond to the albuterol?
I see.
SBS.
No, not in the neb, not in the albuterol neb. We're adding it to the albuterol SVN.
Oh, the SAMA.
Yeah, it's the backdoor drug. Right, ipratropium, right? We can add in ipratropium to the albuterol if the albuterol's not working as well as we need it to. So that's a possibility. It's not first-line treatment like it is for COPD. All right, it's a secondary treatment. Okay, so we have the continuous neb going at 10 milligrams an hour. We might have added an ipratropium to it, possibly. They're still really in distress. What do you think we want to get started? Because it takes 4 to 6 hours to start working.
The systemic steroid.
Yes, so now we're going to say, you know what? We've got the continuous neb going. Let's start a systemic steroid. All right, so we need to get an IV. We're going to get solumedrol going, okay? Because we know it's going to take hours to start taking effect to try to decrease this immune response, decrease the swelling. All right, so we're going to do, so that's the second. So if I ask you, your albuterol is primary, I'm going to ask you how to give it. There's 2 ways you give it. And then your systemic steroids are going to be the next drug that you're going to give. Are we good with that?
Yeah.
Yes.
Okay. All right. So corticosteroids, usually when they're in distress, if they come into the ED, they're going to put them on high doses to try to stop this swelling or edema or reaction. So they might have them on steroids during their entire duration in the hospital, right? Because they've admitted them. They're staying on their IV steroids. And when they go home, they'll probably put them on oral steroids. So they'll take pills when they go home. And usually they try to wean patients off of steroids because if they abruptly stop the steroids, they can have an adrenal reaction. Their adrenals actually shut down, and that can really cause a problem with these patients. Okay, so the rule is if they're on steroids longer than, it used to be 5 days. Now I think it's even longer. High doses for at least 5 days. If they're on for about 5 days, they don't wean them. But if they're on longer than that, then they must be weaned. So that's kind of the new study, the new theories is how they're doing it. If they're on longer than that, they must be weaned. So if they're on like 60 milligrams of prednisone at home, they're going to wean them down. The next day they might be on 50. The next day they might be on 40. So they really taper them down and they wean them down to a low dose before they dramatically stop it. Because your adrenals they stop producing cortisol when you're taking steroids. So if you dramatically stop the steroids, your renals are not producing cortisol, and that can cause problems with you. So they wean it down so that their adrenals will start producing cortisol before they completely stop the steroid. So that's kind of the physiology behind it. Okay. All right, so let's look at these steps real quick. So we remember these steps. What time is it? 11 o'clock. Okay, so we have our steps here, right? SABA PRN, step 2. I want you to really look at this chart and put this back into memory, okay? Step 2, so we have our SABA, and then you see how we add a low-dose inhaled corticosteroid, right? So that's vital because of the inflammation. We need to manage that inflammation. So these are old GINA guidelines, but this is how you're going to be tested on your boards. That's why we're keeping them this way. So that you'll take your boards and you'll answer the questions according to these guidelines and pass your boards. That's our goal, is to get you to pass your boards. Clinically, GINA guidelines have changed, and now GINA guidelines say, you know what, we realize that the inflammation is the main problem. So whenever we give a SABA, we must also give an inhaled corticosteroid. So now clinically, when you go to the hospital, you're going to see them treating patients differently than what you're seeing with this STEP program, this management program. So the new GINA guidelines say every time you give a SABA, you must give an inhaled corticosteroid. Because if the patient needs to take a SABA, that means there's inflammation. I mean, it makes sense. So they must take their inhaled corticosteroid to combat that inflammation, okay? So that's the newest change for the new GINA guidelines. So step 2, we could add the leukotriene inhibitors, okay? And if they do add that, so we're going to block those leukotrienes from circulating in the blood, in the sputum. So if we block that, or if we add that, we're going to keep it throughout all the stages, okay? Then we have level 3. So remember, you can do 2 ways. You can go to low dose, or moderate dose, medium dose ICS, or you're going to add a LABA. Okay, that's the long acting. And then increase to high dose, or add the LABA and medium dose. And then step 5, you can go to high dose ICS or add your systemic steroids. And this is where they're referring to an asthma expert, a pulmonologist, an allergist, where they will, add those extra drugs that we talked about. So let's talk about these steps here. So right now, I am at step 1, right? I use SABA PRN. So I'm an asthmatic. My PFTs are normal. Well, mine are not normal during off times, but most asthmatics might be semi-normal, maybe a little lower on the flows than normal people. But if I had an exacerbation, my flows are going to drop. Okay, makes sense? Because it's reversible. Your airways go pretty much back to normal when you're not having an exacerbation. Okay, so if let's see if I was around a cat for a long time and I started to have an immune response, and all of a sudden I'm really having an asthma exacerbation, okay, I could go from step 1 straight to step 5 and end up in the ED. All right, makes sense? So at step 5, I might need to be put on IV steroids. All right, then I respond, I do really well, and I might go home on oral steroids and then be weaned down back, and I go back to step 1. So that's how these steps work. Questions?
Yeah, Johnny, I'm a little bit confused about this ICS oral steroid.
Okay. What are you confused about inhaled corticosteroids versus oral? Oral steroids, you're taking, oral means you're taking pills that you do at home.
Oh, okay.
Yeah, systemic steroids are just, you're either taking pills, or if you're in the ED, you're going to be getting an IV, and they're going to give you steroids through the IV.
Okay. Okay, thank you.
Uh-huh. Any other questions? Okay. So, evaluating the treatments, and we already talked about how we evaluate with the peak flows, with the FEV1s. We already discussed that. So I want you to be able to tell me, how would you evaluate your patient? So you can look at these tools. If they're not using their rescue inhaler, right? The goal is not to use your rescue inhaler. If you're using it more than a few times a month, you're not managing your asthma, okay? If the patient's not waking up at night, that means that you're managing the asthma, okay? Decrease exacerbation. So I just want you to be able to tell me a few ways to evaluate how the treatment's working for the patient, okay? We already talked about that. Okay, so emergency room, we've talked about that a little bit here. So when you're assessing the patient, you're going to be seeing, can they speak? If they can't speak, then that's a problem, okay? Then they're really in distress. If they can't speak or only can say a word or two, then they need to be treated right away, all right? Okay, so really the first drug you are going to give, and when you're asked this on a test, the first drug you give is going to be oxygen, all right? So when a patient comes in, we usually give them a continuous neb right away, but that might take a minute. So when they come in, you're going to give them a nasal cannula at 46 liters per minute. This is what I want you to write, okay? 4 to 6 liters per minute for an asthmatic. On your boards, on the exams, on quizzes, you could pick 5, and that would be fine. So we never want to give a toxic FiO2 to a patient initially, unless we're giving a non-rebreather, which we're not doing for asthmatics. So just make note of that. What is the FiO2 for 5 liters per minute, approximately? Forty, good. 40, right? 24, 28, 32, 36, 40. I use my fingers. That's how I do it. 40% about. So you want to stay in the range of about 40 to 60% when you're treating these patients. Over 60%, you're getting into toxic FiO2s, and we want to stay away from that if possible. So we're going to start them with 46 liters initially, which probably be for just a couple of minutes, because then you're going to be putting them on a continuous neb for the most part, or some kind of nebulizer. Does that make sense to you guys? So treat their hypoxemia, start their SABAs, all right? Whether it's Q 20 minutes times 3 or it's a continuous neb. And you're going to start, and then if they're not responding, you're going to start their steroid, IV steroid. Is everybody clear about that? Because I'm going to ask you that on how to treat a patient in the ED. Any questions? No? Okay. Here's IM. What's IM mean? IM. Intramuscular. Okay. Intramuscular epinephrine. So we used to treat asthmatics in ED with IM epinephrine, but we don't do that anymore. We don't routinely do that because of the effect it has on the heart. So they'll normally just do that if you have a anaphylactic allergic reaction to something. Then they would do an EpiPen, right? You guys have all heard of an EpiPen. Okay. So these goals I want you to know also. Goals for continuous nebs. So you're going to be with this patient. You're not leaving them. All right. Probably they'll be in ED, and even if you have to see other patients, you're still going to be monitoring them. So you're just looking for them to improve. It's what I want you to know here is a 10% improvement in the peak expiratory flow rate within the first hour. So the goal is to improve Up to 50% are predicted. So if their normal is 400 and they do a peak expiratory flow for you and they're at 100, you want them to get to 200. That'd be 50% of predicted. Okay, and you want to try to maintain SATs in the 90s. You don't want to really get below 90s. Okay. Okay, so these are some other things that we can do. So we already talked about our steroids. We can do heliox therapy. You learned about that already. What does heliox do that oxygen doesn't do? Is it a heavy gas, a gas? Hello?
I know it's combined with helium and.
I thought I lost you. Yeah, so heliox is a light gas. Not all hospitals have it, but it's a light gas that you can use, and you can hook it up to a non-rebreather, and you can run your nebulizer, as you see over here in this picture, to the heliox tank, so that it's a lighter gas, so you can get the medication down further into the airways. The heavier gas the oxygen's heavier, so it doesn't make it down as far, and the patient can feel like they're getting air. Okay, so it's going to decrease their work of breathing. All right, so you don't have to know the 2 grams infusion over 20 minutes. You don't have to know that. That's just there for your information. But I looked it up, and this does a lot more than just help decrease their work of breathing. I'm sorry, magnesium sulfate is what I researched. So magnesium sulfate, that's the dosage. And magnesium sulfate is a smooth muscle relaxer. So we give it to patients who are in labor, that we want to stop their labor, because it's a smooth muscle relaxer. Okay. It actually stops the calcium from entering into the muscle to cause the contraction. So that's how that works. But it also, I found out, decreases histamine release from the mast cell. So I thought that was pretty interesting. And inhibits acetylcholine release from the cholinergic receptors. So I thought that was kind of interesting. So mag sulfate is an option if they're not responding to the other therapies. So you won't see it that often, but that could be something you could suggest to the physician. Let's see. So as I said earlier, we don't routinely do ABGs. We don't routinely do chest x-rays unless we hear fine crackles maybe in an area of the lung that could represent maybe the patient has pneumonia, right? Then they would do a chest x-ray to rule that out. That's only if you hear an adventitious breath sound in a certain lobe, all right? So we talked about when we hospitalize. When the patient starts improving, so their peak expiratory flow rates are doing better, the doctor's going to think about discharging the patient. So they're going to send them home on oral steroids, and they've probably already started the inhaled corticosteroids. So they're going to wean them down over a couple weeks, and they're going to instruct them to go follow up with their healthcare physician. Okay. So we've already discussed that. Okay, so this is getting near the end, and then we can do some fun stuff. Everybody with me still?
Yeah.
Yes.
I know that's a long lecture. So when do we need mechanical ventilation? Well, we have talked about it a little bit. It says here, we don't use NIV, non-invasive ventilation. So that's like CPAP, BiPAP, which you're going to learn about next week. So that's with a mask. You can ventilate a patient with a mask from a ventilator, and that has not shown to help asthmatics out. So if they're getting so severe that they're going into stage 3 for their blood gas, right, which is a normal acid-base balance, and they're trending to start retaining CO2, then non-invasive is not going to work. And prolonging intubation is going to increase their mortality rate. So that's an indication that this patient needs to be intubated. So you're going to intervene with the physician and say, hey, I think this patient needs to be intubated. Because if you think about it, you're at that bedside more than the physician is. He's probably got a whole ED, probably has 10 patients, maybe more, that he's treating. So he's relying on your expertise to let him know when your patient needs to be intubated. Okay? So you're monitoring this patient very, very closely. So silent chest, as I tried to tell you guys earlier, and I started choking myself, silent chest is when you're not hearing air movement. So if you listen to breath sounds and they're like very decreased, it doesn't have to be totally silent, but it could be diminished bilaterally, right? And the patient's really working to breathe and they're saying, I can't breathe. And maybe somebody else listens and says, oh, they have clear breath sounds, because you hear clear breath sounds, but they're very diminished. That tells you that they're not moving a lot of air. Okay, so you listen, it sounds diminished, and then let's say you give them a bronchodilator, and all of a sudden you hear wheezing. That's a good sign. That means that their airways have opened up somewhat, and now you actually hear wheezing, so now you're moving some air, so you're headed in the right direction. So when you have a silent chest, it means minimal air movement, and you need to intubate this patient right away. So all of these, if they're drowsy, if they start getting confused, that means they're hypoxemic and they're losing oxygen to the brain. So that's a clinical sign. Okay. If they're getting tired because they've been breathing 30 times a minute all night long and they're tiring out, that's a sign that they can't keep going. Speaking, if you see a lactic acidosis, that's all signs that, hey, you know what, I think it's time. Or I always find out if the patient says, I need to be intubated, I listen to them because they know their bodies. And if they say that, they've been intubated before. Okay, and I always pay attention to my asthmatics on the floors, and I always ask them that, have you ever had a breathing tube in your throat? If they say yes, you better believe I watch them closer because they can turn on you very quickly. They can their airways can constrict down quickly. So I pay attention to them a little closer than another asthmatic, let's say. And the other thing I want to tell you is if you hear clear breath sounds, but they tell you that they can't breathe, you might not be able to hear inflammation, but they can feel it. So listen to your patient and you know, don't say, well, you can breathe fine, you have clear breath sounds. You know, don't say that. Be receptive to what your patient is telling you. Okay, that's really important. That makes a good therapist when you listen to your patients, because they know what they feel. You only know what you hear. Okay, let's see. So for asthmatics, if they do need to be intubated, we're going to try to use a large tube, not a small tube, because they already have restricted airways, so we don't want to increase the resistance. If you have to sedate, remember, avoid morphine. We're going to use low tidal volumes, which we'll teach you about when we talk about ventilating asthmatics. And we're going to do that because a lot of these asthmatics, if they're being intubated, they've already air trapped. So you're not going to be able to get a large volume in anyway. And we're going to have to allow their CO2s to rise. That's just what we're going to have to do, because we're not going to be able to ventilate to normal blood gases. And that's called permissive hypercapnia, and you'll learn about that in ventilation. Okay? As soon as they break, meaning as soon as their airways open up and stop constricting and some of the edema goes down, then we try to wean them as soon as possible. Questions? So here's some other things that I put in here. Smoking cessation. So if your asthmatic smokes, maybe most hospitals have smoking cessation programs. You could help them out and give them a pamphlet, encourage them to quit smoking, or tell somebody in their household not to smoke. I always ask the asthmatic, what do you do for a living? I had this asthmatic patient. He was in his 20s. He came in so much to the hospital. I was like, what do you do for a living? He said, I'm a painter. I was like, you got to find another job, honestly, because he's reacting to, the paint. So I always talk about occupational hazards for these asthmatics because they got to take care of their health. Maybe that job is not suited for them. Maybe they need a different job, because your health comes first.
Cessation.
NSAIDs. So asthmatics, not all of them, but this is a different phenotype that react to NSAIDs. What do NSAIDs stand for? Anybody? Henry, do you know?
No, I'm not sure.
Okay. It stands for non-steroidal anti-inflammatory drugs. Okay? And those NSAIDs are like ibuprofen, Advil. Those are non-steroidal drugs that are anti-inflammatory drugs. Okay? That's what NSAIDs are. And believe it or not, there is a phenotype. Obesity, asthma is a phenotype. So what's the cure for that? To lose weight. All right? That's a phenotype. GERD is gastroesophageal reflux disease. So if you're refluxing acid all the time, that acid could irritate the airways. All right? And that could be a cause for bronchoconstriction. And hypomagnesium, that's one that I didn't know about, and I thought that was really interesting. So did some research, and I found this study from this university, and it talks about low magnesium levels, which causes high levels of histamine. So I thought that was pretty interesting. Okay. This last thing, I just added this to the PowerPoint. So I went to the new GINA guidelines for COVID-19 to see if they had any new information. And this is what I found. So it says that asthmatics are not at increased risk for getting COVID-19. If they're in the hospitals, we should try to give them MDIs, all right, to COVID-19 patients now who are hospitalized. We should give them MDIs and try to avoid nebulizers because the nebulized particles can spread COVID. So that's why they're recommending that. But if it's life-threatening, then you'll have to give them one. But this is what they prefer. Okay. We're going to avoid spirometry, and they recommend all asthmatics to get the COVID-19 vaccine because they're at risk. Because they already have lung involvement issues. So this virus is a lung-eating virus. So we need to definitely protect the asthmatics. Any questions? Let me get back to you guys. Okay. That was a lot of information. We're going to stop. I guess we can keep recording. So I have a couple of videos that I want to show you real quick. Okay. And so I'm going to share with you again. So and everybody understands the treatment path for these asthmatics? We're good. Okay. All right, so let's show you a couple of videos. And in the videos, I want you to tell me, after each video, we'll talk about it, but I want you to pay attention and to tell me, what do you see what do you see clinically? What is the patient presenting clinically? And that's what I want you to tell me after each one. Okay. So let's take a look at these. Oh, I need to share with you again. So we're going to share my application screen, audio. And we're going to pick this one. Can you guys see this?
Yeah.
Yes.
Okay, so let's look at the first one. See if it works. It's thinking about it. Here we go. Can you see this?
15-year-old Chris is having a severe asthma attack. His immune system has made what could be a fatal mistake and is shutting down his airways. Without help from the medical team, Chris's body may shut down completely.
You're not going to die. You're not going to die. You'll be okay.
The breathing tubes in Chris's chest are squeezing tightly shut and filling with sticky mucus, blocking his vital oxygen supply. If he's not treated soon, he will die.
This is a really life-threatening episode of asthma. Asthma is pretty common in our community, and most of the time it's not this life-threatening, but this one is quite serious.
Chris's allergic reaction has tricked his immune system into shutting down his airways, blocking vital oxygen to the rest of his body. The drugs are supposed to help the muscles around Chris's airways to relax, but there is a problem. The mucus stops the drugs from reaching his blood supply.
Through the vein to try and help it out, because sometimes the lungs close down too much for this stuff to work. So.
Time is running out. Chris's body takes emergency action. His shoulders and neck muscles swing into action to help inflate his lungs. But even this is not working. As the pressure mounts, the team must find a treatment to get the drugs past the mucus. Chris is by no means an isolated case. 1 in 9 Australian children suffer from asthma. But for Chris, the situation is looking dangerous.
Chris is currently having Ventolin or salbutamol through a nebulizer, which he's breathing into his lungs. This acts on the muscles around the small airways and helps to open them up. Unfortunately, sometimes when the airways are very closed down, the salbutamol doesn't reach the areas that it needs to get to. The inhaled Ventolin is not working, then we often will go to a different form of medication. Again, a relaxant for the muscles around the small airways, and it helps to open those airways up. And it's given as a one-off dose over about 10-15 minutes in severe asthma.
Inside Chris's body, the airways start to open as the drugs take effect. Air finally returns to Chris's lungs, inflating the 300 million tiny air sacs.
Chris, you feeling a bit better?
At last, he can breathe.
Chris seems to be feeling a lot better now. The intravenous medications seem to have taken effect. He still is very tired because he's been working very hard with his breathing, but we're a lot happier with his clinical progress now.
Chris was
Okay. Can you guys hear me?
Yeah.
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 Great. Okay. So what did you see? You're the therapist going in the room. Tell me some of the clinical signs that you witnessed.
I saw that he was in the tripod position.
Okay, so he wasn't laying back. All right. So I love it when sometimes nurses will call you in and they say this patient's in distress and they're laying back flat in the bed. You know they're not in distress. Anyone in distress is going to be leaning forward, trying to breathe. Okay. So you saw the tripod. What else did you guys say?
Wheezing. I heard.
Well, you can't see wheezing, but you did see what?
Inability to speak.
What did you say?
He's having trouble speaking.
Right. He was having trouble speaking, so he could only say a couple words. What else?
He was using his accessory muscle.
Yes, accessory muscles he was using. Yes. Did you see any retractions? Supraclavicular, substernal. He was retracting. So he's really working to try to pull air into his lungs. Did he look panicked?
Yes.
Yeah.
Yeah, he did. So you can see someone in that state is really reaching for help, right? And so our job is to stay calm, because that's scary, seeing somebody that can't breathe like that. That can be scary for us. So your job is to, maintain composure and let the patient know that it's going to be okay. You're going to take care of them. And that's what they want to hear, right? They want to know that they're going to get better. If you tell them, like, this is the end for you, buddy, hey, nothing's getting better on this, they're going to be scared. So you need to give them positive reinforcement. Okay. All right. So let's take a look at this trampoline asthmatic.
Hey, how you doing, good?
Oh, it's never stopped me from anything.
Fine.
What time we missed it up?
You need to take that pen out of your pocket. I'm sure you're going to be very serious.
That's right. All right, back up, Rock.
Okay, what's the number to beat here?
133.
All right, 250. Coming up.
Don't set your goal sights too high. My side view is funnier before.
Should be burning. You alternate legs.
It doesn't work.
He's all yours, Jesse.
I'm so tired. I can't.
I'm thinking of a title. That boy jumps on trampoline. Has asthma.
50 more seconds.
Did it go down a minute?
Yes.
How many?
121. That's pretty good.
Oh, man.
It's over. Oh, it's over.
Do you need an inhaler?
You're going to blow it over.
I think I do, actually.
Make sure you get that on video.
Do you know how to use it?
Is this the same as mine?
Just hold it away from your mouth and spray it and
Wait, what?
hold your breath.
What do you mean?
You look white.
I'm dying. That's why. Did that do anything for me?
Well, you're supposed to hold your breath. You are right. Okay, well, I don't even put mine on there. You're not supposed to get it close to you. Okay, blow out, and then I'll spray it, and you hold it. And then hold it there. That should have helped a little bit, though.
You waited too long.
But you got some, though.
That
was good.
Spray.
I don't want him to get too much, because then it makes you real shaky. I think he's got... His color came back.
I'm okay. I'm okay.
Can't breathe.
Oh, man. That was fun. You started out strong, buddy. Oh, that was...
Is that high?
Let's
get
You can do crystals?
It's purple.
I might as well give it a shot.
I have food jumping around in my face. I did it.
Yeah, I have asthma.
Sorry, guys, I was talking to Nina. Okay, so what did you think about that one?
You saw immediate tachypnea as soon as his breathing started acting up.
Right, so he didn't even realize, I guess, that he had asthma-induced or exercise-induced asthma, and he really started getting short of breath, and everybody's laughing at him. Nobody's listening to him when he's really saying he can't breathe, and they're all laughing at him. Did you see how quick he responded to that albuterol inhaler?
Yeah.
He was in serious distress, really. And then all of a sudden he uses that inhaler and he could breathe like immediately. So if it's the initial response with the bronchospasm, it can be treated quickly with the bronchodilator, right? If you catch it before it goes into the inflammation stage. So I thought that was an interesting video also. So let's look at this third one. This is a paramedic who has an asthma exacerbation.
I went to work that morning and I had this overwhelming sick feeling. And I went to work and I thought, oh man, I just got to get into work and they'll see that I don't feel good and then I can go home.
That morning, it was really the first call of the morning. I hadn't really seen her. I could only seen her passing at the station. It was a simple medical aid. We happened to arrive the same time the ambulance did, so there was already several other paramedics there along with us.
We grabbed the equipment and we went upstairs in the elevator and I walked out and I went to walk up to the patient and I felt super short of breath.
We were considering calling an ambulance for her, taking her to one of the urgent care. She kind of denied, I think I'm feeling better, drove back to the station. She immediately got in her car and left, was going to go to her own doctor.
It got worse and worse as I got home and I thought, nothing's getting better. So I told my roommate I need to go to the ER now.
Trey came in through our emergency department with the abrupt onset of a very severe asthma attack. She was treated very aggressively with the usual kinds of therapies for an asthma attack, but she got very much worse within a short period of time, and shortly after being admitted to the hospital, had to be intubated.
I actually told one of the chiefs that was there helping me as a friend, don't let him intubate me because I don't think he's going to come back. I just had that impending doom feeling.
She had one of the most severe cases of an asthma attack that we've ever seen, and was not only not responding well to the usual medications, but even while she was on the mechanical ventilator breathing machine, she wasn't doing well.
It was right around the same time that we're finding out that this is very serious, and there might not be, she might even last a day. And then we hear about this bypass type of machine, is how it was described to us, more or less in layman's terms, this ECMO device, and the idea behind it.
A simple way to think of it is like putting a patient on a heart-lung machine where the blood is removed from the body through a large tube placed in a vein in the body, and then circulated through an artificial lung. So we were able to turn the ventilator way down so that the pressures went way down and allowed her lungs to rest and for the treatments for her asthma to take effect, at which time then we could get her off the ECMO.
That thing saved her life. I mean, she was the right candidate. She had the physical fitness before and the right mindset, but if it wasn't for that, there was no way she was going to live, I think.
Given her age and her occupation, I mean, it's even more of a happy story because of, the good that she can give back to the community and people that she takes care of.
Everything has returned to normal. My pulmonary function levels are 125%. I've had 2 separate doctors tell me that I have supernatural lungs. I've done CrossFit, I've done dirt biking, I've gone surfing, and I've been able to return to every activity that I've done before. There's not a day that goes by in my life since I've been here that I haven't told my story. And my story is about the staff at Sharp Memorial. They really worked hard for me. I had phenomenal care. They really performed a miracle. And I thank them every day that I walk around, and today's a good day. Thank you. Because these people at Sharp, they really did the job.
Okay. All right, let me stop sharing. So that was pretty intense, right?